Welcome to the deep dive. We are really excited to have you with us today.
Yeah, thanks for joining us. We have a massive topic to cover.
We really do. So, the mission today for you listening is to conquer this incredibly dense, um, just really detail-rich study guide for your Nursing Health Assessment Exam 3.
It is a beast of a study guide. Let's just be honest about that up front.
It totally is.
Yeah.
I mean, we're talking the thorax, the lungs, the heart, the peripheral vascular system.
Right, it's a lot of ground to cover.
It's so much. But, usually when you unfold a map, there's this expectation of static precision.
Like a city grid. Right.
Exactly, like a city grid. The streets are permanently drawn in ink. The buildings are fixed in their coordinates. You can point your finger to say, there it is. That intersection never moves.
Because it's fixed.
Right.
Right.
But the moment you step into the world of advanced human anatomy, and particularly health assessment, that static map becomes utterly useless.
Utterly useless because it's a living system.
Yeah, when you're looking at the human body, especially the cardiopulmonary and vascular networks, you are trying to map a landscape that is constantly expanding. It's contracting. It's shifting under immense pressure.
And physically remodeling itself, based on the demands placed upon it.
Exactly. So, okay, let's unpack this. Because for you, the learner prepping for this exam, or really anyone who's just insanely curious about the body, we aren't going to treat this like a boring list of anatomical terms.
No, memorizing flashcards won't help you understand the big picture.
Right. Instead, we're going to trace the actual flow of life, from the first breath drawn into the lungs to the heart pumping that oxygenated blood, all the way down to the furthest vessels in your toes.
Because clinical symptoms are just downstream physical manifestations of altered physics and chemistry.
Oh, I like that way of putting it.
Yeah, so before we can identify what goes wrong, we really have to map the territory and understand how the machinery actually works in a normal state.
Let's start with the engine room, basically.
Hmm.
The thorax, the lungs, and the mechanics of breath.
The mechanical enclosure of the respiratory system.
Right. So your thoracic cavity is the space extending from the base of the neck all the way down to the diaphragm. And to protect the vital organs here, you have the thoracic cage.
Which isn't just a rigid box, by the way.
No, it's an articulated, highly flexible enclosure. It's made up of 12 pairs of ribs. But the study guide makes a big deal about how they are categorized.
Right, architectural differences. So the first 7 pairs are the true ribs.
Now, they're called true ribs because they have a direct connection to the sternum. Right.
Exactly. They have their own individual strips of costal cartilage that connect directly to the sternum. It gives the upper chest wall incredible stability.
Okay, so then you have the 5 pairs of false ribs.
Yeah, ribs 8 through 12.
And looking at the anatomy, their attachment is way more indirect. Like ribs 8, 9, and 10 don't even reach the sternum directly.
They don't. Their costal cartilage basically sweeps upward and fuses with the cartilage of the 7th rib above them.
Which creates that flexible sort of cartilaginous margin right along the bottom of the rib cage.
And that flexibility is crucial. If the whole cage was just locked down with rigid bone, the lower lungs couldn't fully expand when you take a deep breath.
That makes total sense. And then the last 2 pairs, the 11th and 12th ribs, are the floating ribs.
Right. They have zero anterior attachment whatsoever.
They just sort of end in the muscle.
Yep. Their cartilaginous tips just terminate freely in the lateral abdominal musculature. They protect the kidneys in the back, but allow maximum flexibility for the torso in the front.
Okay, so holding the anterior part of this whole cage together is the sternum. And structurally, it's divided into 3 sections.
The manubrium at the top, the body of the sternum in the middle, and that little xiphoid process at the bottom tip.
Right. But there is a very specific topographic landmark on the sternum that your study guide highlights aggressively, the sternal angle.
Or the angle of Louis, yes. The clinical utility of this landmark really cannot be overstated for an assessment.
How do you actually find it on a person?
Well, if you place your finger in the suprasternal notch, that U-shaped hollow right at the base of your throat, and trace directly downward onto the sternum, about 5 centimeters, you'll feel a horizontal, bony ridge.
It's like a flight bump, right?
Exactly. It's the articulation point where the manubrium meets the body of the sternum. That continuous ridge is the angle of Louis.
And why is it so vital for a nurse to find this exact bump?
Because if you're trying to listen to specific heart valves or locate a lung consolidation, you have to know exactly which intercostal space your stethoscope is resting on.
And you can't just start counting from the collarbone.
Oh, trying to count ribs by starting at the clavicle is a nightmare. It's notoriously inaccurate because the first rib dives deep under the clavicle and is covered by muscle.
Ah, so the angle of Louis is your foolproof starting point.
Precisely. It is perfectly contiguous laterally with the second rib. The moment you locate that ridge and slide your fingers to the right or left, you are physically touching the second rib.
So the soft depression right below your finger is the second intercostal space.
You got it. And from there, you can systematically palpate downward, counting every single rib and space accurately, no matter the patient's body type.
It also serves as this massive internal crossroad, though. Like, it correlates with vital structures buried deep inside the chest.
It does. It marks the exact horizontal plane where the upper border of the heart's atria sits.
And it's also where the trachea splits, right?
Yes, the precise location where the trachea bifurcates into the right and left mainstem bronchi. And if you project that plane straight backward to the spine, it hits the T4 vertebra.
That is wild. One little bump tells you where everything is.
Which is why you also need to master the imaginary vertical reference lines. You need a coordinate system to document what you find.
Like the mid-sternal line down the middle, the mid-clavicular line dropping from the center of the collarbones.
Right, and the axillary lines on the sides of the chest. If you hear an abnormal sound, you have to marry the horizontal intercostal space with the vertical reference line to pinpoint it.
Okay, so let's follow the anatomical pathway down. We pass through the larynx and enter the trachea. This is that flexible tube, about 10 to 12 centimeters long.
And it descends anterior to the esophagus.
Right, and to prevent it from collapsing when you inhale, it's reinforced by these C-shaped rings of cartilage.
And the geometry of those C rings is a brilliant evolutionary adaptation.
How so?
Well, they're incomplete circles. The open part of the C's faces toward the back, right up against the esophagus.
Oh, so when you swallow a huge bite of food.
Exactly. The esophagus needs room to expand forward. The soft membranous backing of the trachea yields to that pressure.
So the food passes down without getting stuck against a hard, rigid pipe. That is brilliant.
It really is. Now, down at that angle of Louis, the trachea bifurcates, and the structural asymmetry here between the right and left bronchi is a classic exam focus.
Yeah, the right main bronchus is wider, is shorter, and it drops at a much steeper, more vertical angle than the left one.
While the left door is longer and takes a sharper horizontal turn.
Because it has to go around the heart, right? The heart takes up that space on the left.
That's right. And that asymmetry dictates the pathophysiology of aspiration.
I have this note here, comparing the right bronchus to an express lane.
That's a perfect analogy. Because it's wider and steeper, it acts as the path of least resistance. It's a direct downward chute.
So if someone swallows a Lego or inhales some food, it's almost always going to funnel straight down into the right main bronchus.
Almost always. Which perfectly explains why aspiration pneumonia is overwhelmingly localized to the right middle or right lower pulmonary lobes.
Okay, now the study guide calls the trachea and these primary bronchi dead space, which sounds kind of grim.
It just means no gas exchange happens there. They hold around 150 milliliters of air, but their sole physiological function is just to be a transport corridor.
A heavily guarded transport corridor, though. They're lined with cilia and goblet cells.
Right. The goblet cells secrete a continuous sheet of sticky mucus to trap dust and pathogens.
And the cilia act as the janitors.
Exactly. These microscopic, hair-like projections beat in a synchronized upward motion. We call it the mucociliary escalator.
Sweeping all that gross, contaminated mucus up to the throat so you can swallow it or spit it out.
But if you look at chronic pathology, like a chronic cigarette smoker, the inhaled toxins literally paralyze and destroy those cilia.
So the escalator just shuts down.
Entirely. The goblet cells are still making mucus, but there's no mechanism to sweep it up. It pools in the lower airways.
Which is why smokers get that harsh, persistent cough. They have to rely on sheer mechanical force to get the debris out.
Precisely. So, moving from the corridors to the actual functional tissue, we have the lungs.
And again, we see asymmetry. The right lung has 3 lobes, upper, middle, and lower, separated by fissures. But the left lung only has 2.
Just an upper and a lower to make room for the cardiac notch.
For a nurse doing a physical assessment, knowing where these lobes are on the outside of the chest is critical, isn't it?
Absolutely. For instance, the posterior chest, the back, is almost entirely occupied by the lower lobes.
And the upper lobes project mostly onto the front chest wall.
Right. And the right middle lobe is particularly elusive. It does not project onto the back at all. You can only listen to it from the front chest, roughly between the 4th and 6th ribs.
Good to know.
Yeah.
Now, to keep these lungs from rubbing against the ribs and suffering friction damage, they're wrapped in pleura.
the pleural membranes. You have the visceral pleura, which is intimately stuck right onto the lung tissue itself.
And the parietal pleura, which lines the inside of the chest cavity. And between them is the pleural space.
Though calling it a space is almost misleading, it's more like a potential vacuum containing just a few milliliters of lubricating fluid.
You mentioned it's like a drop of water between two glass panes.
Exactly. You can slide the glass panes back and forth easily with no friction, but if you try to pull them directly apart,
The surface tension makes it basically impossible.
that cohesive force physically couples the lungs to the chest wall. So when the rib cage expands, the parietal pleura pulls outward, and the vacuum transmits that force to the visceral pleura, pulling the lungs open.
But what if someone is severely dehydrated or has inflammation, like pleuritis?
That lubricating fluid volume decreases. The two rough, inflamed pleural surfaces start dragging against each other with every breath.
Ouch. And as a nurse, you would auscultate a pleural friction rub, right?
Yes, a harsh, grating, leathery sound. It sounds just like two pieces of rough leather rubbing together.
Okay, so that covers the mechanics.
Yeah,
But wait, I have to stop here and push back on something in the notes because it feels totally counterintuitive.
that's that.
It says here that our primary drive to breathe isn't because we need oxygen. It's because we have too much carbon dioxide. Is that really true?
It is absolutely true. The control mechanisms governing your respiratory drive are mostly monitoring the pH of your cerebrospinal fluid.
And the pH is tied to carbon dioxide.
Yes. When carbon dioxide diffuses into the bloodstream, it reacts with water to form carbonic acid. An accumulation of CO2 hypercapnia drives the pH of your blood down into an acidic state.
Wow, so the brain sensors detect that acidity.
The central chemoreceptors in the medulla are exquisitely sensitive to it. The moment the pH dips, the brain fires off signals to the diaphragm demanding increased ventilation.
So breathing is really an emergency response to blow off volatile acid in the form of CO2.
Exactly. Breathing is an acid-base balancing act as much as an oxygen delivery system. Low oxygen hypoxemia only triggers a secondary backup system if the primary hypercapnic drive fails.
That is mind-blowing. Okay, so segment 2. When breathing goes wrong, now that we know how it's supposed to work, how does a nurse physically assess when the lungs are failing?
Visual inspection is your first diagnostic clue. You look at the geometry of the chest wall.
A healthy adult chest is kind of elliptical, right?
Yes, the antero-posterior diameter, the depth from front to back, should be roughly half the width across the shoulders, so a 1.2 ratio.
But in someone with COPD or emphysema, we see a barrel chest where the ratio is 1.1.
Because of chronic hyperinflation, emphysema destroys the lung's elastic recoil. The lungs fill with air, but they can't snap back to push the air out.
So the air gets permanently trapped.
Right. And over a period of years, the immense outward pressure of these constantly inflated lungs physically pushes the rib cage outward. The ribs freeze into this rigid, cylindrical barrel shape.
There are other deformities you have to look for too, right? Like pectus excavatum?
The funnel chest, yes. A deep depression of the lower sternum. If it's severe enough, it can physically compress the heart.
And pectus carinatum is the opposite, where the sternum protrudes outward like a pigeon's chest.
Exactly. And you must evaluate the spine, too. Severe scoliosis or kyphosis, that exaggerated hunchback curvature, can severely distort the chest volume.
The notes mention something super interesting about athletes here.
Oh, the swimmers. Yes. Competitive swimmers frequently develop thoracic kyphosis and internally rotated shoulders.
Just from the repetitive overhead muscular contraction pulling on their bones.
Yep. The body continuously adapts its skeletal structure to its mechanical function.
Okay, so if someone is in acute respiratory distress, you're looking for signs they are fighting for air.
You look for nasal flaring, a primitive reflex to open the airway. You look for cyanosis, that blue discoloration of the skin.
And the tripod position. I've seen patients do this, leaning forward, hands planted hard on their knees or a table.
It's a desperate attempt at survival. By locking their arms and fixing their shoulders, they are essentially reversing the origin and insertion of their accessory muscles.
Wait, how does that work?
Muscles like the pecs usually move your arms. But if your arms are locked tight, contracting your pecs pulls your rib cage upward and outward instead.
Oh, wow. So they're using their arm muscles to forcefully haul their chest open to get air in.
Exactly. It's a massive red flag for impending respiratory failure.
Okay, moving from visual to tactile.
Yeah.
Palpation and percussion.
Right. Feeling the density of the lung tissue using tactile fremitus.
This is where you have the patient say 99 while you feel their back with the base of your hand, right?
Yes. You're analyzing how acoustic vibrations travel from the voice box down through the lungs to the chest wall.
And sound waves travel better through solid stuff than through air.
Precisely. A healthy, air-filled lung dampens the sound. You just feel a moderate vibration.
But if they have lobar pneumonia, where a lobe is just packed solid with fluid and pus,
That consolidated lobe becomes an excellent acoustic conductor. The sound waves race through it and you'll feel a marked increase in fremitus on your hand.
conversely, if there's an abnormal pocket of air, like a pneumothorax where the lung collapsed, the air acts as a barrier and the vibration decreases or vanishes.
You also palpate for crepitus, which is a very distinct pathological sensation.
The notes say it feels like popping microscopic bubble wrap under the skin.
It does. It happens when air escapes from a punctured lung and gets trapped in the subcutaneous tissue. Subcutaneous emphysema.
That sounds terrifying. Let's talk about percussion, tapping the chest wall.
You're setting the tissue into vibration. Normal lung tissue produces a clear, hollow sound called resonance.
And if the lungs are overinflated, like an emphysema, you get hyperresonance, a booming sound.
Right. But if that air is replaced by fluid like pneumonia or a tumor, the sound gets muffled. It produces a dull thud.
Which brings us to auscultation. Actually listening to the breath sounds. There are normal ones, like bronchial sounds over the trachea,
Harsh, loud, and high-pitched because it's a wide, rigid tube.
and vesicular sounds over the peripheral lung fields.
Soft, low-pitched, rustling sounds, like wind blowing through the leaves.
But the real challenge is adventitious sounds, the abnormal ones, like wheezing.
Wheezing is a continuous, high-pitched musical sound. It happens when an airway is severely narrowed, like in an asthma attack.
The air velocity increases as it squeezes through, making it vibrate musically, like whistling.
Exactly. Then you have crackles, which are discontinuous popping sounds. Fine crackles sound like rolling a lock of hair right next to your ear.
And that's caused by alveoli snapping open.
Yes, sticky fluid-coated alveoli suddenly popping open during inhalation, often heard in early heart failure.
But coarse crackles are totally different. They sound like ripping open Velcro.
Because that's the sound of air violently colliding with thick, pooling mucus in the larger bronchi. You'll hear that in severe pulmonary edema.
And then there's raunchy, which is like a low-pitched snoring sound.
Usually caused by thick secretions partially obstructing the airways.
So if I hear an abnormal crackling or snoring sound, do I immediately sound the alarm?
No, absolutely not. The very first clinical intervention when you hear those sounds, especially raunchy, is to ask the patient to cough forcefully.
Oh, because coughing can clear the secretions.
Exactly.
Yeah.
It generates massive shearing force. If the sound was just a loose mucus plug, the cough dislodges it, and the lungs might sound perfectly clear right after.
So you verify it's just mucus and not permanent tissue damage. That's a great tip.
We also assess the rhythm of breathing. And severe pathology can radically alter this.
Like Cheyne-Stokes respirations.
A deeply pathological pattern. Breathing gradually gets deeper and faster in a crescendo, then slower in a decrescendo, ending in complete apnea for up to 20 seconds.
That sounds incredibly stressful to watch. Why does it happen?
It's a failure of the feedback loop in the brainstem, often seen in end-stage heart failure. The circulation is delayed, so the brain is constantly overcorrecting to old blood gas levels.
And Biot's respiration is even more chaotic.
Pure neurological chaos. Random deep breaths interrupted by unpredictable apnea. It indicates catastrophic brainstem damage or severe head trauma.
But then there's Kussmaul respirations, which the expert explicitly ties to diabetic ketoacidosis, or DKA.
Yes, abnormally deep, rapid, labored breathing.
And this ties back to that CO2 acid concept.
Exactly. In DKA, the blood becomes dangerously acidic. The brain detects this and triggers maximum hyperventilation, not to get oxygen, but to forcefully blow off massive volumes of acidic CO2.
It's chemically dragging the blood pH back to a survivable level.
It's brilliant compensation.
Okay, really quickly on sputum colors. White is usually viral. Yellow or green is bacterial.
Because of the white blood cells fighting the infection.
Rust-colored sputum indicates TB or pneumococcal pneumonia from old blood. And pink frothy sputum is a massive emergency.
The hallmark of acute pulmonary edema. Severe heart failure forces plasma and red blood cells into the alveoli, mixing with air to create a literal pink foam. The patient is drowning in their own fluid.
Which is the perfect transition to segment 3, the pump. The lungs got the oxygen, now the cardiovascular system has to deliver it.
Right, let's map the heart.
It's located in the mediastinum, from the second to the fifth intercostal space. But here's where it gets really interesting for a learner. The naming convention is completely backward.
It trips everyone up. When we think of a base, we picture the bottom. but the heart is an inverted pyramid.
So the broad, flat portion at the top where the aorta and the vena cava attach, that is the anatomical base of the heart,
Correct, up at the second intercostal space.
which means the apex, the pointy tip of the left ventricle is at the bottom, down at the fifth intercostal space.
You have to grasp that inverted orientation because localizing heart sounds relies entirely on knowing the base is superior and the apex is inferior.
Okay, so let's look at the walls of the heart. The myocardium is the thick muscle doing the pumping.
And when you compare the chambers, the difference in thickness is striking. The atria are just thin-walled reservoirs.
Because they just gently squeeze blood down to the ventricles. But the ventricles face totally different workloads.
The right ventricle only pumps blood to the lungs. It's a short, low-pressure trip, so it's relatively thin.
But the left ventricle has to pump blood to the entire body, up to the brain, down to the toes, fighting immense systemic resistance.
To overcome that massive afterload, the left ventricular wall is physically 3 times thicker than the right ventricle.
Form follows function. And to keep the blood moving in one direction, we have valves.
The atrioventricular, or AV valves, guard the junction between the atria and ventricles, the tricuspid on the right, the bicuspid or mitral on the left.
But with the immense pressure of the left ventricle squeezing, what keeps those delicate mitral valve leaflets from just blowing inside out into the atrium?
The chordae tendineae.
The heartstrings.
Yes. They are tough, fibrous cords anchoring the valve leaflets directly to papillary muscles on the ventricle wall. When the ventricle contracts, the papillary muscles contract too, pulling the cords taut.
Like a parachute, locking the doors shut so they don't prolapse. That is so cool.
The semilunar valves, the pulmonic and aortic, don't have those cords. Their moon-shaped cusps just snap shut under the weight of the blood trying to fall backward.
Okay, so the mechanical squeeze requires an electrical spark. The heart has automaticity.
Meaning the cells generate their own electrical impulses without the brain telling them to?
The SA node is the lead conductor of the orchestra here, right? Located in the right atrium.
It acts as the intrinsic pacemaker, firing 60 to 100 times a minute. That electrical wave sweeps across the atria, causing them to contract.
That's the atrial kick that tops off the ventricles with blood.
Then the signal hits the AV node, the critical electrical speed bump.
Wait, it intentionally slows the signal down.
Yes, for about 1/10 of a second. It has to delay the signal so the atria can finish squeezing their blood into the ventricles before the ventricles are told to fire.
Otherwise, they just squeeze against each other.
Exactly. After the delay, the spark shoots down the bundle of His, into the bundle branches, and through the Purkinje fibers.
Wrapping around the bottom of the ventricles, making them squeeze powerfully from the bottom up, wringing the blood out toward the top.
And the SA node is the main pacemaker. But if the conductor faints, the AV node, the assistant, takes over.
It has its own backup rate of 40 to 60 beats per minute, a built-in failsafe.
On an ECG, this whole sequence is the PQRST wave. The P wave is atrial depolarization. The massive QRS complex is ventricular depolarization.
It's massive because the ventricles have so much muscle mass. And the T wave is the reset, the repolarization.
So when you listen to the heart with a stethoscope, you aren't hearing this electricity.
You're hearing the physical valves forcefully snapping shut. Lub-dub.
Systole is the contraction phase. Diastole is the relaxation phase. The first sound, S1, the lub, marks the start of systole.
That's the sound of the pressure slamming the AV valves, the tricuspid and mitral shut.
And because those valves are lower in the heart, S1 is heard loudest at the apex, down at the fifth intercostal space.
Then the ventricles relax, pressure drops, and the blood tries to fall backward, snapping the aortic and pulmonic valves shut. That's S2, the dub.
It marks the start of diastole. And because those valves are at the top, S2 is lightest at the base, the second intercostal space.
So S1 loudest at the apex, S2 loudest at the base. But what about extra heart sounds, the gallops?
S3 and S4. They happen during diastole and indicate problems with ventricular compliance.
Let's start with S3. The rhythm sounds like the word Kentucky. Kentucky, lub-dub-da.
S1, S2, S3. This occurs very early in diastole. When the AV valves open, a massive volume of blood rushes into a ventricle that is overly compliant or already overfilled.
So it's the sound of blood sloshing violently into a flabby ventricle.
Yes. It can be normal in young athletes, but in older adults, it's the hallmark acoustic signature of congestive heart failure and severe fluid overload.
Okay, what about S4? That sounds like Tennessee, Tellub-dub. S4, S1, S2.
That happens late in diastole. It's the opposite problem. The ventricle has become chronically stiff, often from years of high blood pressure causing massive hypertrophy.
It's too thick to expand properly.
So at the end of diastole, the atria have to contract with tremendous force to literally ram blood into that stiff wall. That violent collision produces the S4.
And if a patient has both an S3 and an S4?
That's a summation gallop. It indicates catastrophic heart failure.
Wow. Let's touch on murmurs quickly. They're swooshing sounds, not clicks.
Caused by turbulent blood flow, like a calm river suddenly hitting a narrow, jagged gorge.
Often from a stenotic valve that's calcified and won't open fully, forcing blood through a tiny pinhole. Or a leaky valve blowing blood backward.
We grade them 1 to 6. A grade 6 is so loud you can hear it with the stethoscope slightly off the chest.
And if it's a grade 4 or higher, you can physically feel it on the chest wall. A thrill. It feels exactly like a purring cat against your palm.
To map these sounds, you use the APE to man anatomical landmarks.
Aortic, pulmonic, Erb's point, tricuspid, mitral, moving in a specific Z's pattern down the chest to interrogate every valve's acoustic shadow.
But the assessment doesn't stop at the chest. The neck vessels are direct windows into the heart's status. Let's look at jugular venous distension, or JVD.
The jugular vein drains blood from the brain straight down into the superior vena cava and the right atrium.
And critically, there are 0 valves between the jugular vein and the right atrium. It is an uninterrupted fluid column.
So it's basically a barometer for the right side of the heart. If the right ventricle is failing, the pressure backs up.
It acts like a traffic jam backing up out of the right atrium up into the neck veins.
You assess this by sitting the patient at a 30 to 45 degree angle. If the vein is visibly bulging and pulsating up their neck, their central venous pressure is way too high.
Right next to those veins are the carotid arteries. You listen to them for Brute's swooshing sounds, indicating plaque buildup.
But wait, if I'm checking the carotid pulses, shouldn't I just grab both sides of the neck at once to compare them? It seems faster.
Absolutely not. You must never do that.
Why? What happens?
2 things. First, you're physically cutting off the primary blood supply to the brain. The patient could pass out. Second, and more dangerously, the carotid sinus is packed with baroreceptors pressure sensors.
Oh no.
If you compress both sides, the body incorrectly registers a massive, dangerous spike in blood pressure. The brain responds by firing vagus nerve signals to drastically slow the heart and dilate blood vessels.
So their blood pressure totally bottoms out and they code.
Exactly. You could trigger massive syncope or cardiac arrest. Only ever palpate one carotid artery at a time.
Good to know. Moving down to the wrists, there's the apical radial pulse deficit. This takes 2 nurses.
One listens to the apical pulse at the chest for a full minute, while the other simultaneously feels the radial pulse at the wrist.
They should be identical, right? Every heartbeat pushes a wave of blood to the wrist.
Usually, yes. But in arrhythmias like atrial fibrillation, the heart beats irregularly. Some of those ventricular contractions are empty or weak.
You hear the heartbeat on the chest, but it doesn't generate enough pressure to reach the wrist.
So the chest count is high, the wrist count is low. That mathematical difference is the pulse deficit. It tells you exactly how many beats are failing to perfuse the extremities.
Which brings us perfectly to segment 5, the highways and back roads, the peripheral vascular system.
The heart generates the pressure, but the vessels have to manage the trip.
And arteries and veins are completely different anatomical beasts. Arteries are thick, muscular, high-pressure highways carrying oxygenated blood away from the heart.
They have a dense layer of smooth muscle and elastic fibers. When the heart ejects blood, the artery physically stretches and then forcefully recoils to push the blood forward.
That recoil is literally what you feel when you take a pulse.
But veins operate under totally different physics. They carry deoxygenated blood back to the heart. They are thin, highly distensible, and very low pressure.
Because by the time the blood gets down to the microscopic capillaries in your toes, the driving pressure from the heart is basically gone.
Right. And now that venous blood has to travel a meter straight up, fighting gravity, to get back to the heart, and veins don't have a pump.
So they rely on 3 mechanical hacks.
First is the skeletal muscle pump. Every time you walk, your calf muscles squeeze the deep veins, milking the blood upward.
Second is the one-way valves inside the veins. Blood gets squeezed up, and when gravity tries to pull it back down, the valves snap shut to stop it.
And third is the respiratory pressure gradient. When you inhale, your diaphragm drops, creating a massive vacuum in your chest that literally sucks the venous blood upward from your abdomen.
That is so deeply interconnected, it's amazing. But on the exam, the biggest challenge is distinguishing arterial insufficiency from venous insufficiency.
The ultimate showdown. The clinical presentations are total opposites.
Okay, let's start with arterial insufficiency. This is when the high-pressure supply line is blocked, usually by plaque. Blood cannot get down to the legs
The tissue enters a state of profound starvation and ischemia.
because no warm core blood is arriving. The leg will be cool to the touch. The skin gets shiny and dry, the hair falls out, the nails get thick and ridged.
And you assess it using elevation power. If you raise the patient's leg, gravity overcomes the weak arterial flow, and the leg turns stark ghost white.
But when they dangle the leg over the edge of the bed, gravity helps the blood rush down into the starving capillaries, and the leg flushes a dusky purplish-red color. Dependent rubor.
And obviously the pulses in the feet will be severely diminished or totally absent.
And if the tissue actually dies, you get arterial ulcers. Because they are driven by oxygen starvation, they are excruciatingly painful.
Usually forming on the very tips of the toes or heels, they look like someone took a perfect hole punch tool to the skin. Deep, circular, with smooth borders.
And totally dry, right? Because there's no blood flow to make them weep.
Exactly. Pale and necrotic. Now compare that to venous insufficiency. The arterial supply is fine, but the venous return is broken. The one-way valves have failed.
So the blood can't get back UP?
It stagnates and pools in the lower legs. This creates immense hydrostatic pressure, which forces blood plasma directly out of the veins and into the surrounding tissue.
The result is massive, progressive, kitting edema. Their legs swell up with fluid.
And because arterial blood is still pumping into the swollen leg, it will actually feel warm to the touch.
And then there's that distinctive brown discoloration. What causes that?
As red blood cells are forced out into the tissue, they break down. The body leaves behind permanent deposits of indocyanine iron, which stains the skin a leathery dark brown around the ankles.
The venous ulcers are totally different too. They aren't caused by starvation, they're caused by fluid overload, so they're relatively painless.
Yes, they form around the medial ankle. They are shallow with highly irregular, jagged borders. And because the tissue is constantly weeping fluid, they are distinctly wet ulcers.
So dry, painful, punched out pale toes equals arterial. Swollen, brown, wet, painless ankles equals venous.
Perfect summary. Now, what if the venous return isn't just sluggish, but is completely blocked by a solid clot? A deep vein thrombosis, or DVT.
Usually in the calf or thigh.
Yeah.
Virchow's triad stasis, vessel injury, hypercoagulability.
It acts like a concrete dam. All venous return below that point stops instantly. The leg gets acutely swollen, hot, red, and incredibly tender.
If it's a clot, shouldn't a nurse massage the leg to help break it up?
Oh God, never. Never palpate or massage over a suspected DVT.
Because it'll dislodge.
If you massage it, you can break it loose. It becomes a highly mobile embolus. It will shoot up the vena cava through the right side of the heart and wedge directly into the lungs.
A massive pulmonary embolism, completely cutting off blood flow to the lungs.
It's frequently fatal. Your assessment of a DVT must be entirely visual. Maybe measuring the calf circumference with a tape measure, but never massaging.
Okay, understood. A less lethal issue is varicosities, varicose veins.
Dilated, rope-like superficial veins. The superficial valves fail from years of standing or pressure, and the blood falls freely backward.
To test for this, you do the Trendelenburg test. Elevate the leg until the veins drain, tie a tourniquet on the thigh, and have them stand.
If the valves are broken, when you release the tourniquet, the veins instantly engorge from the top down as the blood free falls backward.
Okay, wrapping up with the lymphatic system. It's the secondary drainage network.
It vacuums up excess interstitial fluid and large proteins and filters it through lymph nodes before dumping it back into the blood.
The asymmetry here is wild. The right lymphatic duct only drains the right arm and right upper body. The massive thoracic duct drains literally everything else.
Right, and if this drainage gets blocked, say by a mastectomy removing lymph nodes, you get lymphedema.
The arm swells massively, but it's different from venous edema because it's packed with proteins, not just water.
It triggers inflammation and scar tissue. Chronic lymphedema is hard, non-pitting swelling. The skin feels like thick armor.
2 final clinical tests. The Allen's test for the hand.
Crucial before sticking a needle in the radial artery. The hand is supplied by both the radial and ulnar arteries.
You can press both at the wrist, have them pump their fist until the palm turns white. Then you let go of only the ulnar artery.
If the palm flushes pink within a few seconds, the ulnar artery is healthy enough to supply the whole hand. If it stays white, you cannot puncture the radial artery, or you risk ischemic amputation of the hand.
The last test is capillary refill, pressing the fingernail until it turns white.
The color should flush back in less than 2 seconds. A delay means severe peripheral vasoconstriction, maybe from shock or extreme cold.
Wow. We have traced air from the lips all the way down to the toes, from negative pleural pressures to electrical myocardium sparks to hydrostatic venous pooling.
It's an incredible journey. Mastering the physics and chemistry behind these symptoms is what elevates you from just a student memorizing facts to a true clinician.
And speaking of that, before we sign off, I want to go back to what you said about the swimmers. It totally changes the perspective.
It does. A study guide trains you to look at the body as a static machine that's slowly breaking down. Find the broken valve, the blocked artery.
But it's not a static machine, it's a living diary.
The body physically alters its own architecture based on how you live.
Right.
The left ventricle builds massive muscle to fight high blood pressure over decades. The chest wall literally remodels its bones for a smoker's overinflated lungs.
The body tells a story.
Exactly. So the next time you are conducting an assessment, listening to the heart, feeling the pulses, don't just ask what's broken. Ask yourself, what is the architecture of this specific body? Tell me about the life this person has lived.
That is a profound perspective to carry into clinical practice. Best of luck conquering Exam 3, everyone. Trust your understanding of the mechanics, trust the pathophysiology, and keep mapping that dynamic terrain. We'll catch you on the next deep dive.